Hello, my name is Andrew Edmondson. I'm the clinical director of the CDG clinic at the Children's Hospital of Philadelphia, and I'm an investigator with the Frontiers in CDG Consortium. This webinar is going to be about COVID-19 and CDG. I gave a similar webinar a little over a year ago, and we felt that it was time to update the community given all of the developments and additional knowledge that we've obtained about COVID-19 and CDG. So today's webinar is going to talk about COVID-19. We're going to talk about SARS-CoV-2, the infectious agent, and some underlying glycobiology, and then update you on what we know about COVID-19 and CDG, and end with some recommendations, as well as trying to answer the most frequently asked questions that we hear from CDG patients and families. So COVID-19 is short for coronavirus disease 2019, and it's the actual disease that's caused by the severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. As I'm sure you're familiar with now, the symptoms of this disease are frequently cold-like or fever-like illnesses with fevers and chills, coughs, shortness of breath, fatigue, muscle aches, headaches, loss of taste or smell, sore throat. There can be congestion, runny nose, nausea, vomiting, diarrhea. It can really be a broad range of symptoms, and particularly in younger individuals who contract COVID-19. What's become clear is that COVID-19 is a disease that primarily affects older individuals. And if you compare different age groups to sort of young adults between 18 to 29 years of age, as you get older, you have increased risks for hospitalization and death. And younger individuals, children, are at decreased risk for both of these outcomes. We also know that the severe outcomes from COVID-19, hospitalization and death, seem to increase as you have additional comorbid conditions. An update on COVID-19 in children specifically, to try and focus on this, because the disease is often described as more mild in children. But to date, the most recent numbers that I could find was that there have been more than 6 million infections in US children with COVID-19. And of those, 24,498 have required hospitalization, or just under 1% of COVID-19 cases, which is certainly less than the number of hospitalizations and the percentage of individuals hospitalized who are older. But more than 20,000 cases requiring hospitalization is still a significant number. And it's not an entirely benign disease in children because of those infections, about 0.01% have resulted in deaths. So to date, approximately 600 children in the US have died of COVID-19. And while that's significantly less than adults, it's certainly not an entirely benign disease in children. There are children who are dying of COVID-19. Another aspect of COVID-19 that's very particular to children is a condition known as multi-system inflammatory syndrome in children, or MIS-C. This seems to be a delayed sort of immune response to COVID, and is defined as children, so individuals who are less than 21 years of age, who then develop fever or laboratory evidence of inflammation and have more than 2 organ systems involved, and have evidence of having had COVID infection. And to date, about 0.1% of infections in children result in this sort of delayed severe systemic inflammatory response to the virus, with more than 5,000 US children having been diagnosed with MIS-C to date during the pandemic. So while not as severe as in adults, this is still a significant disease that affects children. So the actual infectious agent, the severe acute respiratory syndrome coronavirus 2, that's here pictured, is a envelope virus that has the spike glycoprotein at the top, sort of surrounding this virus. Here's another view of that spike glycoprotein, and all of those colored balls that are on this spike protein are the glycosylations. So you can see there's a lot of glycosylations, and here's another schematic to show you how all of these glycosylations can occur on the spike glycoprotein. So a heavily glycosylated protein. The spike glycoprotein uses another glycoprotein that's expressed on our cell surfaces, the ACE2 receptor, which is also a glycosylated receptor, to bind and find its way to get entry into the cell. So there's a lot of questions about COVID-19 and CDG. Questions about, are individuals with CDG at higher risk because of their multiple health conditions? We know CDG is a multi-system disease that affects many organs. So are those diseases sort of a higher risk factor for individuals? There's also been questions of, could it be that children or individuals with CDG are at lower risk because SARS-CoV-2 spike glycoprotein and the ACE2 receptor are both glycosylated? Are those glycosylations important to the infectious process, to the entry of the virus? And because of the dysfunctional glycosylation in CDG, could that actually be decreasing the risk of developing a severe infection? There's also been questions because immune deficiency has been documented in CDG patients. And so could they be at higher or lower risk of developing the various symptoms or complications of COVID-19 infection because of that immunodeficiency? Are they at risk of having a more severe infection because they can't fight it off? Or are they at less risk of having MIS-C and long COVID complications because they don't have that same inflammatory response? And the truth is, a year ago when I first gave this webinar, and even a year later, is there's very little actual data still on COVID-19 and CDG specifically. But I'm going to share with you what information we have and try and put things into as much perspective as possible for you. But beyond the biological infectious process and the biological responses, it's very clear to all of us that COVID-19 is affecting everyone, even if you don't have an infection. The disruptions we've had to life, to caregiving, to care in hospitals, to the disruptions of supply chains, social services, were all significantly affected by this pandemic. So to date, we have had many more infections in CDG patients than we had a year ago when I gave this seminar. So we've had many patients with PMM2 CDG who've gotten COVID-19, several with ALG3, a couple with MPD1, patients with ATP6AP1, PIGN CDG, GMPPB CDG, NGI1C DDG. And this list is not comprehensive, but certainly reflecting that we have had many infections in individuals with CDG, and it's not restricted to particular types of CDG. And it does not appear that specific types of CDG are resistant to having infection with SARS-CoV-2. So I think that helps us to answer the question of, are CDG patients at lower risk of having an infection with or COVID-19 infection, because we see that individuals can get sick with COVID-19. As far as severe complications, we've not seen a lot of severe complications in these patients, although I do have to say that individuals with CDG are not entirely safe from having a severe outcome. We know of 2 individuals who died who had COVID-19. Because it's only a few individuals, it's not entirely clear if it was directly related to the COVID-19 or a part of their the other disease process going on, and the COVID-19 was more incidental. But I have to acknowledge that we have had CDG patients who've died and been positive for COVID-19. The other individuals have largely been children, and some of them have been asymptomatic or nearly asymptomatic, and found more so because of routine screening of exposed individuals. And some of them have had mild infections. Overall, I would say that the spectrum of disease symptoms that we see in the CDG patients who've had COVID-19 has been very similar to what we see in other healthy US individuals of similar age. We don't seem to see a lot more severe disease in these patients. So I tend to think of our CDG patients as having very similar susceptibility and similar risk of having more severe disease as we see in other individuals, other healthy US individuals of the same age. So that leads us to vaccination. So the big sort of change that has happened since I last gave this webinar is that we now have vaccines available. And as of earlier this week, the CDC is recommending vaccination for all individuals aged 5 and older. The younger age groups, the 5 to 17-year-old children, are only eligible at this time for the Pfizer vaccine, whereas individuals 18 years and older are eligible for Pfizer, Moderna, or the Janssen vaccine. So what can you expect from vaccination to COVID-19? So the vaccine does induce an immune response, and so there can be some side effects, which are largely evidence that the body is building protection and not something to be worried about. So like with all vaccines, or many vaccines, you can have some pain, redness, or swelling at the site of the injection. You can also have some other symptoms in the rest of the body, being tired or fatigued, having a headache, some muscle pains, and some individuals will develop chills and a fever, or can have some nausea from the vaccine. These are really normal signs that the body is responding to the vaccine, and they usually will go away within a day or 2. Some individuals don't have any side effects and feel fine, and that's not evidence that the body isn't responding to the vaccine. What we get more concerned about are serious, even life-threatening side effects from the vaccine, and these are what make the headlines in the newspaper. And I want to address them directly because it is important to acknowledge that there can be some very serious, rare, very rare side effects. The first one that sort of made the news was the risk of anaphylaxis, which came from a component in the mRNA vaccines and occurs in approximately 2 to 5 out of 1 million individuals vaccinated. So that's 0.0002 to 0.0005% of vaccinated individuals. Now, if you know that an individual has a susceptibility to components in the vaccine, then you can reduce that risk. And so before getting an mRNA vaccine, you'll be asked if your or your child is allergic to any of the components, and the one that's most typical to cause the anaphylaxis is to polyethylene glycol. So individuals who are allergic to polyethylene glycol are contraindicated to get the mRNA vaccines. The second serious side effect that made headlines was thrombosis with thrombocytopenia or low platelets. And that came specifically from the Janssen vaccine and occurs in 7 out of 1 million vaccinated individuals, or 0.007%. And this rate is the highest rate in women that are 18 to 49 years of age, whereas men or women outside of that age range have a lower risk. And then what's been particularly causing attention to the pediatricians as well as families who have children is that as the Pfizer vaccine was rolled out to the younger individuals from ages 12 to 17, we saw a risk of myocarditis. So this is inflammation around the heart. Symptoms are usually chest pain or some difficulty breathing. And we found that there's a rate of 54 out of 1 million individuals, largely in males between ages 12 and 17, and largely more so with the second dose of the vaccine than with the first dose of the vaccine. While this is a serious side effect, the myocarditis it causes can be treated, and individuals who develop it generally recover fully. So how do these rare serious side effects compare to the risks of COVID-19 infection? Because we're trying to weigh the risks of vaccination versus the risks of infection. We want to make sure that the cure is not worse than the disease. And as I've shared with you, the seriousness of COVID-19 in children does not seem to be nearly as high as it is in adults. And so when we get to thinking about children and vaccination, it's a bit of a different balance between the seriousness of vaccination or the seriousness of the disease versus the cure and vaccination. So if we compare these rates to the rates of disease in children, we see that children who get infected with COVID-19 are somewhere between 16 to 4,000 times more likely to be hospitalized from COVID than to get anaphylaxis. And they're 20 to 50 times more likely to die from COVID than they are to have anaphylaxis. For the thrombocytopenia, I'm giving the benefit of the doubt and using the highest rate we see, but compared to the rates of this among children, it would actually be far less risk of having the thrombosis. And in that case, we have more than 1,000 times risk of having the thrombosis than to be hospitalized from COVID, as well as 14 times more likely to die from COVID than to get this thrombosis with thrombocytopenia. When it comes to the myocarditis, which is the more frequent serious side effect that we see in children, we see that children are 160 times more likely to be hospitalized from COVID than they are to have myocarditis from vaccination, as well as they would be 2 times more likely to die from getting COVID than they would to have myocarditis with the vaccine. So that puts some of this in perspective of the frequency of these rare side effects, which are very rare, and the frequency of severe outcomes from COVID infection, which are also rare in children, but more common than these serious side effects. So the serious side effects we see from vaccination are all more common than, or the serious side effects from COVID infection are far more common than the serious side effects from vaccination, which helps us weigh out our balance. The other thing that's been addressed with vaccinating the younger children, in part because of these perceived risks, is that the vaccine that was approved for the younger children, approved for ages 5 to 11 earlier this week on November 2nd, uses a lower dose than that used for the older children and for adults. And if you look at the side effects that are reported in those vaccinated individuals in the trial, they have fewer side effects. They don't really have any of the severe side effects, but those are all very rare. So it's not common that we would necessarily see the very severe side effects. But the more common side effects, the fevers, the myalgias, the not feeling quite so great, is lower in younger children who receive the lower dose of the COVID-19 vaccine than the older children and adults who receive the higher dose. And so our hope and our expectation is that we will also see fewer of the severe side effects in children, in younger children with the lower dose. So how do these vaccines work? So the mRNA vaccines, which are the Pfizer and the Moderna vaccine, use mRNA. So the vaccine is in a syringe that's delivered through a needle into an intramuscular injection, delivers mRNA, which is a message to the cell, and that mRNA goes into the cell and begins to tell the cell how to make the spike glycoprotein. So the cell makes the spike glycoprotein. That's the only component of the virus it makes. It doesn't make the other parts. And you can't form a live virus from just the spike glycoprotein alone. But the body recognizes that spike glycoprotein is not supposed to be there. It educates the immune system so that the immune system can recognize that spike glycoprotein if an individual is exposed to the true SARS-CoV-2 virus in the future. How does the viral vector? So this is the Janssen vaccine. The Janssen vaccine uses a different virus, a adenovirus that doesn't cause disease, and uses that virus to deliver a DNA message into the cells. So rather than RNA going in, it's DNA. The DNA in the cells is then made into mRNA. And that mRNA then codes for the spike glycoprotein, which is expressed, and the immune response responds to it. Again, with the viral vector vaccine, you're only delivering message for the spike glycoprotein, and you can't make a live SARS-CoV-2 virus from just the glycoprotein alone. So both of these methods are using the body's own production system in order to generate the spike glycoprotein and educate the individual's immune system. And so that, again, raises the question, if we're requiring CDG patient cells to make the spike glycoprotein, it may not be glycosylated properly, and so will the vaccination still be effective? This hasn't been studied rigorously. So I can only share with you the data that we have and what we know, which at this point is not much and is mild and primarily anecdotal. But we have had adults with CDG who've been vaccinated in the first rollouts of the vaccines for adults, and they have not had any of the serious side effects. Some of them have had the mild side effects that we anticipate can happen with fevers and myalgias and not feeling so great, but it clears up within a day or two. And so I'm personally aware of individuals with PMM2 CDG, PGM1 CDG, SLC35A2 CDG, and ANGLI1 CDDG, who have all been vaccinated without any serious concerns. And those vaccinated CDG individuals have not gotten COVID-19. So it appears to be safe and effective, probably among similar rates that we see in the general population, but it will take additional time to know for sure. And so we hedge some of our recommendations, which leads to our recent updated recommendations. So the clinical investigators at the Frontiers and CDG Consortium in the US with our multiple sites, as well as international sites, in conjunction with talking about our recommendations with the priorities of our patient advocacy groups, have come up with recommendations. These are meant to be broad recommendations and acknowledge that there may be some individuals for whom they don't apply, but our expectation, keeping all of our diverse CDG patients in mind, is that most CDG patients will not be exceptions to our recommendation, and that our recommendations will likely apply to the majority of CDG patients. And so the recommendation by our CDG experts at FCDGC is for CDG and NGLY1 patients, their parents and caregivers to be vaccinated against COVID-19. If they're eligible, we think you should be vaccinated. If you feel that there's an exception, we think you should talk to your CDG experts. You should talk to the physicians who are directly responsible for your care to discuss your concerns, to discuss why you feel you may be an exception. But by and large, we believe that the balance is in favor of CDG patients, parents, and caregivers receiving the vaccine and being protected against COVID-19, even in light of understanding the mild symptoms of COVID-19 that are typical in younger individuals and the very rare risks of vaccination. We believe that the balance is in favor of vaccination. And so we support your pursuing vaccination. There's multiple safe and effective COVID-19 vaccines now available, several for adult individuals over than 18, and now in the US available and recommended for individuals 5 years and older. And so we recommend that vaccination. Because we haven't been able to generate the data yet on how effective the vaccination is specifically in CDG patients, we also continue to recommend other prevention protocols, continuing to wear a mask that covers nose and mouth, social distancing, particularly from individuals who are ill, washing hands in soap and water for 20 seconds or using hand sanitizer. And so we don't think you should give up on those methods to avoid infection, but we believe the vaccination will be helpful, and we believe it's safe. I know there's a lot of questions, so some of the frequently asked questions that we get that I'd like to try and address. First, what happens if an individual with CDG tests positive for COVID-19 and has symptoms? What should we do? Do you need to go to the doctor or hospital right away? So what we've seen with individuals and what I've shared is that it really depends on how severe the symptoms are. So you should discuss your specific case with the healthcare provider. Having a positive COVID-19 test does not mean an individual needs to immediately go to see the doctor or go to the hospital if their symptoms are mild. As I said, we've had CDG patients with no symptoms at all in a positive test or with very mild symptoms. And those individuals can be cared for at home. And you just treat the symptoms and they generally will do fine. We've had some CDG patients with more severe symptoms, and those patients have needed to go to the hospital. It's going to be like the other infections in your CDG patient or child. It's going to depend on how severe they are. And the things that land them in the hospital, typically, if they always get an infection and go into the hospital, will be the same things that you're looking for if they have a COVID-19 infection. And so we've seen individuals with increased seizures. We've had individuals whose blood glucoses have been more labile, but these are the same symptoms they generally have with other infections. And it hasn't been different with COVID-19. So if they've been in the hospital with many of their other infections, then they may be in the hospital with COVID-19. But not everyone ends up in the hospital. So should people with CDG get a booster vaccination? So our recommendation is that CDG individuals should follow the same guidelines regarding boosters and additional doses of vaccine as non-CDG individuals. We haven't seen a difference, and so we believe that individuals should follow the same guidance and not be seen as an exception to the guidance that's given to the general population at this point. Should antibodies be checked after vaccination? So no, routine checking of antibodies after vaccination is not recommended. It's not something that we routinely do in the general population. It's not something that we need to do in CDG individuals. Is anyone doing studies on CDG and COVID-19 or other viruses in CDG patients? So the short answer is yes, there is ongoing research and ongoing specific research about these infections in individuals as part of our FCDGC natural history study as we're collecting information on the infections, on the side effects, on the complications, and illnesses in CDG patients. And so that's ongoing. And if you are involved in our natural history study, we thank you for helping to give us this information so that we can provide it in forums like this to our patients and families. And if you're not yet involved, then we encourage you to reach out to one of our associated study sites and get involved if you would like to be. CDG is rare, and we all need to work together to be able to answer these questions as definitively as possible and to determine the best outcomes and make things better for all of our CDG patients. So what should I do if my caretaker, nanny, or a family member is positive with COVID? When can they come back to be together with a child? When can they be helpful again? And so the general recommendation that we believe applies in this situation is for a 10-day quarantine period following the onset of symptoms or a positive test. And so this is sort of goes back to the first question on the slide, is what if your child is positive? So they also will need to have a 10-day quarantine period following either the onset of symptoms or that first positive test, whichever is earlier. And then I think one of the biggest questions we hear a lot is folks who are worried about their children getting COVID-19, but also the stresses of the situation and wanting to know, should I send my child with CDG to school? Should I send their siblings to school? Or even should my child participate in in-person therapies? We know there's been a lot of moves toward telemedicine therapies. But at least in my clinic, I hear a lot of concerns and complaints from patient families about how that's not as effective. And so their CDG child is not making the same progress that we would hope if they were receiving those therapies in person. And so again, it's a balance. What are the risks? What are the mitigation strategies, and how can we work with calculated risks to try and ensure that patients do well and aren't getting sick? I think the first point to answer this question, which is going to be a bit longer answer than for those other frequently asked questions, is that recognize and accept the limitations in the situation, this is really tough. The pandemic's been going on for a long time, and it remains a challenge for families. But then realistically assess the risk. I've tried to share with you bluntly the data we have, the actual numbers about the risks. And a lot of that's going to be within the specific situation, your specific child or CDG patient's situation, in that you need to assess their individual risk. What's their individual health history? As I said, if this is an individual who always ends up in the hospital with every viral infection, then it's likely they could also end up in the hospital if they get a COVID-19 infection. What's the risk of other individuals in the home? What are the other personal circumstances? And do those risks to you outweigh the benefits of the CDG individual going to school or participating in in-person therapies? It's also important to look at local testing positivity rates. What is the actual risk of being exposed in your community? It may be low, and that may also be helpful to you. And then what are the risk mitigation strategies and policies that are at school or in therapies? Starting, I think, with vaccination. So we've talked a lot about vaccination, but is your CDG child vaccinated? Are the caregivers vaccinated? Are there requirements for vaccination? Vaccination will make it a safer place. Is there mask wearing that's required? Is there social distancing, hand hygiene, cleaning and disinfecting going on? Are they doing symptom checks of individuals? Are they having classes or therapy groups that are in cohorts? And do they have proactive policies in the event of staff and student diagnoses of COVID-19? Do they have testing available and in place? Do they have policies for the notification regarding staff or student COVID-19 diagnoses? So there's a lot of different factors in place, but I believe that CDG patients, particularly if they've been vaccinated, and for younger children, even in cases when they haven't been vaccinated, I believe that school and therapies can be safe. And as long as you're comfortable with the circumstances around that, I think you can move forward with confidence that the benefits of participating in school and therapies will likely outweigh the risks to your child, but it can individually vary. And so I think you need to take individual circumstances into account. And it's tough, but I know you care about your CDG individuals, and you'll be able to make the right decision for them and for your circumstance. Confidence in you. So those are our most frequently asked questions. I hope this webinar has been helpful to you. I hope you've had most of your questions answered, that you've gotten some additional clarity. If there are still questions, reach out to the CDG expert who knows you most specifically. If these are questions that are specifically about your child and your individual circumstances, speak to the healthcare providers who are closest to you and can best understand your specific situation. You can always reach out to FCDGC investigators. You can reach out to me. You can get the answers that you need to be comfortable with the choices and decisions you make going forward, and to help you understand where things are for you and your children and COVID or CDG individuals. So thank you so much for attending this webinar, and we would be interested in hearing about other topics that you would like to know about in future webinars. So please let us know. Thank you for your time.